Well, good evening, everybody. Welcome to tonight's webinar with Professor Richard Halliwell, which is sponsored by Avacta Animal Health. Now, firstly, I'd just like to provide you with some information about our sponsors. Avacta Animal Health is a UK-based veterinary laboratory providing innovative products and services to veterinary practices worldwide. Their leading SensorTest allergy testing service provides UK-manufactured food, environmental and secondary infection tests which assists companion animal veterinary surgeons in their diagnosis of allergies. They focus on delivering excellent customer service, dedicated client support literature and accompanying website, and have over 13 years' experience in the allergy market. They also supply therapies such as allergen-specific immunotherapy and Staphylococcus clade lysate. Backed by a team of research and development scientists, their latest innovations are aimed at providing laboratory standard ELISA tests to be run quickly and effectively within the veterinary practice. The first proposition being the SensiPod in-clinic testing machine, which will be available later this year. You can find out more information on their products and services at www.avactaanimalhealth.com. Now, I'm now delighted to welcome back to Webinar Club our speaker for this evening, Professor Richard Halliwell. Professor Halliwell received both his veterinary degree and his PhD from the University of Cambridge. He spent 16 years teaching in the USA before returning to the UK as William Dick Professor of Veterinary Clinical Studies at the University of Edinburgh, and he served 6 years as Dean of the faculty. Now a Professor Emeritus, he has served as President of both the American and the European Colleges of Veterinary Dermatology and of the World Association for Veterinary Dermatology. He was awarded a Lifetime Career Achievement Award by the European College of Veterinary Dermatology. And Professor Halliwell continues to teach at St George's University, Grenada, as well as giving presentations at national and international meetings. So thank you very much, Professor Halliwell. I'm now going to hand over to you.
Good evening, and tonight we're going to talk about the neglected subject of feline allergy diagnosis and treatment. So firstly, just an overview of the webinar. We're going to start with the diagnostic approach. We're going to then discuss the feline skin reaction patterns. Then we'll talk about elimination of the non-allergic causes of pruritus. Then moving on, we'll talk about elimination of flea allergy as a cause. Then we are faced with, is it food-induced, food allergy or intolerance, or environmental, i.e. atopic dermatitis. And finally, we're going to talk a little bit about feline asthma. Is this a manifestation of atopic disease? So we've got the 6-step diagnostic approach. Firstly, the segment and history, and we must not try and cut corners on this or we'll make mistakes, we'll miss some obvious things. And it's of course useful to have a little questionnaire form that you can give to the client that they can fill out in the waiting room before you see them. Then we move to the clinical examination, and this will of course include evidence of visible ectoparasites, very importantly, and of course flea dirt. Then we move to the microscopic examination of the skin surface by cytology using cellulose acetate tape strips and skin scrapings. Then we're ready to establish the lists of the differentials. We'll talk about ancillary diagnostic tests to confirm the diagnosis, and then finally the therapeutic approach. Cellulose acetate tape strips are a wonderful technique to visualize what is going on the skin surface. And if we look at the first of these, there we are. We're pressing the cellulose acetate strip on the surface of the skin, and you can do that with your thumb, pressing it firmly on the skin surface. We then take the strip and we mount it on a microscope slide with a free end here that we can dip in the staining solutions. We will not use the fixative because that will mess up the cellulose acetate strip. And we then look at it underneath the microscope. Skin scrapings, and if there is ever a minimum database for examining the skin case, it is probably the skin scraping. It's surprising what you find, and you won't find it if you don't skin scrape. Do superficial and deep skin scrapings as two separate exercises, because some parasites are very superficial, such as Chileriella, and some are much deeper. Squeeze the skin site first, moisten the skin, do broad superficial skin scrapings first, and then return to the same site to undertake deep skin scrapings. And we see here, of course, Demodex, and here we actually see the eggs of Notoedres. Now, unfortunately, one of the reasons why dermatology in the cat is so difficult is the feline skin reaction patterns. The reaction patterns of this feline skin are quite limited, and irritatingly, the same reaction pattern can result from a number of differing etiologies, which is not the case, of course, in the dog. The first of these we're going to talk about is miliary dermatitis, that you're all very familiar with. And oftentimes in the long-haired cat, you'll palpate these little millet seed type lesions rather than visualize them, but here you can see them nicely in a short-haired cat. Crusted papules, usually widespread. And we've got a whole list of possible causes: atopic dermatitis, flea allergy, food allergy. Dermatophytosis or ringworm can appear as a miliary dermatitis. Lice, Chileriella, and some indeed are bacterial in origin and will respond to antibacterial therapy. Trombicular and idiopathic. It's useful to have this term idiopathic. You can give a definitive diagnosis to your client when in actual fact you don't have any idea what's causing the problem. So poll number 1, which is your preferred therapy for the treatment of idiopathic miliary dermatitis? Will you use depomedron, Overid, oral triamcinolone, oral methylprednisolone, atopica, or nothing? Well, the votes are in, and depomedron has the top vote of 55%, followed by oral methylprednisolone 33%, Overid megestrol acetate 2.7%, and of course that actually does have a myriad of side effects. Oral triamcinolone is 1.06%, and atopica is 7%. I'm going to come back to oral triamcinolone because that actually is a very, very useful and effective treatment for pruritus of inflammatory, of allergic origin in the cat. Depomedron, of course, is extremely convenient, but I think people are moving more and more to using perhaps an oral steroid where possible, and if the client will permit it. So the next reaction pattern we're going to talk about is head and neck pruritus, crusting lesions with self-excoriation centered around the head and neck. Food allergy is more likely than atopic dermatitis with this reaction pattern. And Notoedres, if you're in the part of the world where this happens, which really is pretty much absent from the UK as best as I can understand, but does happen in southern parts of Europe, that's another important differential. Then the eosinophilic granuloma complex. Irritating, this complex. It's a bad name for it because they're not all eosinophilic and they're not all granulomas, but we are left with this sort of syndrome. And we've got actually 3, but the 2 most important ones are the eosinophilic plaque, such as you see on the left, well demarcated, raised and oozing plaques with a random distribution, highly pruritic, marked tissue eosinophilia and peripheral eosinophilia. Then the eosinophilic ulcer with ulcerated lesions on the upper lip, and may occur on other parts of the body. Typically, it's at the lip margin. Peripheral eosinophilia is not a feature, and tissue eosinophilia is variable. And if we think of the underlying causes of the feline eosinophilic granuloma complex, any allergic disease can induce this reaction pattern. It is often complicated by bacterial involvement, and the question that people are talking about now is, can bacteria be a sole cause? Workers in the United States have been treating some of these bad cases of eosinophilic plaques with antibiotics alone and seeing a good resolution. So I think we've underestimated the bacterial component. A proportion are still idiopathic. And remember that eosinophilic plaques can be induced by any cause of excessive licking, anything that makes the animal want to lick. Then self-induced or barbered alopecia, the bald belly syndrome, as you see here in the flank of these two cats. Easily diagnosed by looking, doing a trichogram and looking not at the hair bulb, but at the tip of the hair. And on the top you see a nice hair shaft with a nice pointed end, and on the bottom you see one that has been shorn off by the licking of the cat. It's very, very useful to show the client the picture on the bottom. Oftentimes, cats are secret groomers. The client will not accept the fact that the cat is licking the hair out. They're convinced that the animal's hair is falling out. And only by showing the barbered effect of the shorn off hairs can you convince them that the hair is actually being licked out. Major differential for barbered alopecia is psychogenic alopecia. This is most common in the Burmese and Siamese. It's overdiagnosed, I think, in practice. It should respond to clomipramine, the serotonin reuptake inhibitor. Here you see a picture of the dorsum of a Siamese cat that has turned round and pulled all the hair down its back out. Now, it is overdiagnosed, as I mentioned, and this is an interesting study done at Guelph in Canada, the underlying medical conditions in cats with presumptive psychogenic alopecia. 20 cases were referred with a diagnosis of psychogenic alopecia, and psychogenic alopecia was confirmed by a failure to respond to methylprednisolone acetate and by a response to 0.5 to 1 mg per kg of clomipramine. And of course, an allergic disease should respond to methylprednisolone acetate. Food allergy was diagnosed by response to hydrolyzed chicken, ZD, diet by Hills, and response then to a challenge with the original diet. And flea allergy by response to parasiticide therapy. And of these 20 cats, the results are pretty interesting. Adverse food reaction and AD, which is atopic dermatitis, 5. Adverse food reaction alone, 5. Undiagnosed hypersensitivity, 2. Adverse food reaction atopic dermatitis and flea allergy dermatitis, 1. Atopic dermatitis alone, 1. Parasitic, 1. Parasitic and bacterial, 1. Atopic dermatitis plus psychogenic, 1. And this poor cat had atopic dermatitis, food reaction, and psychogenic components as well, 1. And psychogenic, only 2 out of these 20 had psychogenic alopecia alone. So it's not a common diagnosis. And interestingly, the most significant cause of these reactions in this study was food allergy. Then finally, generalized papulocrusted and crusting pruritic lesions. Sometimes cases are seen with generalized skin disease that don't fit readily into any of the reaction patterns noted before, such as you see in this patient on the right. So the workup of the pruritic cat: eliminate visible ectoparasites, flea feces, fleas, lice nits, ticks, trombicula. And then eliminate microscopic microscopic parasites, we've here got notoedries. We've here actually got 2 cases of Demodex in cats, which were provided to me by my daughter who practices in Hong Kong. She was very excited. She had 2 cases in the same week, one of Demodex cati and one of Demodex gatoi, which is a pruritic variant. And we could also have included in here, of course, a case of Chiletiella. And then we assess any role of bacteria or malassezia by doing impression smears or tape strips. And here we see some nice malassezia taken from this cat's mouth. This cat had food allergy with a secondary malassezia dermatitis. And this animal had miliary dermatitis from atopic dermatitis with a significant bacterial component. Don't forget viral diseases. They're not common, but they do occur. And here we see a case of herpes virus reported in veterinary dermatology around the lip margin, the muzzle area. Here we see cowpox. And here we see calicivirus, courtesy of Dr. Jan de Klerk. Often, of course, it will be associated with an upper respiratory tract infection around the nasal area and in the mouth and the paw, the so-called foot and mouth disease of the cat associated with calicivirus. Now, having eliminated all these things, we're ready to sort out allergies. And the first question we have is how common are each of the types of allergies we're dealing with? 2 studies here published recently. The first from Cornell, flea allergy 3.7%, food allergy 2.5%, atopic dermatitis 10.3%, and undiagnosed allergy 15.8%. So even in the most august of institutions such as Cornell, sometimes the allergy is not diagnosed, which of course should be our aim. And then another one from Europe in the bottom, and flea allergy was more common in Europe than in the colder climes of Ithaca, New York. Food allergy 12%, I think they were more precise at looking for food allergy. Atopic dermatitis 20%, and undiagnosed allergy 15%. So I think this tells us that probably in the United Kingdom, in the southern parts particularly, we're going to find flea allergy, food allergy, and atopic dermatitis almost in equal proportions, hopefully with less undiagnosed allergy. How do we proceed? Well, bearing in mind that a diagnosis of atopic dermatitis is one of exclusion in the cat, there's no such thing as classical atopic dermatitis. The sort of patterns you'll see can look like pretty much anything. So excluding things, we'll first eliminate flea allergy, we'll then eliminate food allergy, then number 3, we'll make a presumptive diagnosis of atopic dermatitis and pursue allergy testing for 2 reasons, not really to make a diagnosis, but to identify allergens that may be avoided and or to select allergens for immunotherapy. Nobody should make a diagnosis of atopic dermatitis merely on the results of serology. You have to take into account the clinical signs and elimination of other confounding problems. So let's talk next then, working our way down, about food allergy. The question is it food allergy or intolerance? And quite frankly, for practical purposes, does it matter? It is likely that most cases are allergic, although cases are encountered that are asymptomatic on any home-prepared diet and reactive on any commercial diet, but those are few and far between. Some are clearly IgE-mediated, and some take up to 2 to 4 weeks to relapse and are likely cell-mediated. There is an inherited predisposition suggested in one study of Hungarian cats. There are often concomitant skin and GI signs, 22% in one study, and indeed gastrointestinal disease can be a significant manifestation of food allergy in cats. And in most studies, in some 40 to 60% of cases, lesions appear as head and neck pruritus. So let's go on to poll number 2. You have a patient with recurrent diarrhea and vomiting. You do intestinal biopsies and the pathologist gives you a diagnosis of inflammatory bowel disease. Do you interpret this as most likely resulting from a dietary hypersensitivity, a reaction to a chronic bacterial infection, an idiopathic condition requiring dietary manipulation, an idiopathic condition requiring lifelong immunosuppressive therapy? And the poll is in. And the majority, I think quite rightly, voted for a dietary hypersensitivity. I mean, if you see inflammation in the lamina propria of the intestine, it's responding to something, as far as I'm concerned. And I think it's either got to be something in the food or possibly a chronic bacterial infection, such as is implicated in Crohn's disease of man. And, you know, an idiopathic condition requiring careful dietary manipulation. An idiopathic is really a bit of a cop-out for saying, well, we don't really know what's causing it, which may be the case. But I think that that doesn't obviate the necessity for further pursuit to look for a possible cause. And an idiopathic condition requiring lifelong immunosuppressive therapy, yes, I think some internists, I have arguments with internists on this regard because they don't seem to approach it sometimes from the immunologic standpoint. So I wouldn't want to put a cat, on lifelong immunosuppressive therapy, or a dog for that matter, with inflammatory bowel disease without trying to find out what's causing it. So, I think one of the most classical cases ever reported in the literature of food allergy in the cat was a paper by Gus Walton, Bill Parrish, and Robin Coombs of Coombs test fame in the Veterinary Record in 1968. And they looked at a cat called Ginger, who actually belonged to Ian Silver, and any Cambridge graduates listening might have been taught anatomy, as I was, by Ian Silver. Ginger had a history of intermittent dermatitis and enteritis for 3 years, which had become constant for the past 9 months. Severe pruritus with generalized crusting, self-inflicted lesions, including the head and the ears. And when Ginger was put on a diet of beef and water, the pruritus was reduced in 48 hours, and the lesions healed substantially within 10 days. And after a test meal of milk, severe diarrhea appeared within 4 hours, and pruritus with excessive grooming within 7 hours. Then further investigations, immediate skin test reaction to whole milk antigen was positive. And they also transferred serum to a normal cat and got a positive skin test at the injected site. That's a so-called Prousnitz-Kustner reaction. Biopsies of the jejunum and colon were normal after 8 weeks on the hypoallergenic diet. 4 days after dietary challenge, there was marked plasmacytic infiltrate admixed with some neutrophils and eosinophils in the lamina propria of the ileum, with lesser changes in the colon. So there's a profound inflammatory response reacting to that antigen to which it was hypersensitive. And this was the classical case of IgE-mediated dietary allergy, and I think the best report in the literature still to this day. So let's look at clinical signs in reported case studies in the literature. Pruritus, 100% of cases in all 3 reports. Alopecia in about half the cases. Miliary dermatitis in 20 to 40% of cases. And eosinophilic granuloma complex in about 15 to 20% of cases. And another important study to note, published from Massey in New Zealand, of 128 cats referred with chronic skin and or GI signs, 22 were dietary responsive. So that's quite a high proportion. 10 had skin signs alone, 7 had GI signs alone, and 5 had a combination. And these, I think, were all suffering from an adverse food reaction or food allergy, with dietary alone, dietary and skin combined, and skin alone. If we think of the diagnosis of food allergy, the key points, the clinical signs, can be dermatological, gastrointestinal, or a combination, and remembering that a significant proportion are gastrointestinal alone. The diagnosis is made by response to a hypoallergenic diet trial and relapse upon reintroduction of the original diet or components of it. And that is absolutely key. That is the only way we are going to make the diagnosis. Some clients, once the animal has responded after having been sick for many months or even years, are reluctant to challenge once they've got a favorable response to a diet. But you must impress upon them to do so, because it is perfectly possible that the response was by chance and not specifically to the diet change. And indeed, in studies reported in the literature, some 10 to 15% of animals that respond to a hypoallergenic diet trial will not relapse when challenged. And the next question is how to select the most appropriate diet. Firstly, should we use a limited antigen diet? Well, only some 50% of cases reported in the literature will respond to a limited antigen commercial diet. Should we use hydrolyzed diets? Well, those are sometimes touted as the gold standard, but actually, if you look at reports in the literature, they will detect some 85% of cases, but not 100% of cases. Should we use a careful dietary history to select the most appropriate home-prepared diet? And you've got to be concerned about taurine in the cat, but so long as fresh protein is supplied for the duration of the hypoallergenic diet trial, the animal will be perfectly all right without a supplement. The problem with this is that dietary history is not always known, and this will not allow the detection of cross-reacting antigens. For example, there's evidence certainly in the dog that beef and lamb and milk cross-react. We don't yet have good data in the cat because serology has not been done as frequently in the cat, but that information will emerge, I'm sure, in due course. But the problem of cross-reacting dietary allergens is important, because if the animal is allergic to beef and it cross-reacts with lamb, then giving it lamb, it's still going to be symptomatic. And finally, should we use serology in order to select a diet to which no immune response is shown? This is logical if we're in fact doing with an immunological response. And I think that when combined with dietary history, this is arguably the gold standard. But let me emphasize again, serology is not a diagnosis. It just enables the selection of perhaps the most appropriate hypoallergenic diet, particularly if you're going to use a home-prepared diet. How long does a case of food allergy take to go into remission? Well, we used to say 1 to 3 weeks, but this was a study done by Eddie Rosser from Michigan State, and only 4 of his patients had got better in 3 weeks, with 1 taking 7 weeks and 1 9 weeks. How long to relapse? 15 to 30 minutes, 2, 24 hours, 2, 2 to 3 days, 4, 6 to 8 days, 4, and 10 days, 1. How this variation? I think it probably has to do with the type of immunologic response. IgE-mediated reactions are quick in onset and quicker to get better when the dietary challenge is removed. Whereas animals that takes 9 weeks to go into remission and 10 days to relapse on challenge likely are cell-mediated. So here's a nice cat called Diabolo, which is rather an unpleasant cat on the left, and you can see lesions on the head and neck and lovely miliary lesions on the trunk area. And on the right is Diabolo after the hypoallergenic diet trial. And this is a nice case of Dr. Didier Carlotti's of serious ulcerative, very, very pruritic lesions on the neck and on the right after the hypoallergenic diet trial. So what foods are implicated in cats? Well, they vary according to the local dietary habits. Fish and dairy products have been implicated in the USA and beef and lamb products in New Zealand. How are we going to treat food allergy? We would not, for choice, want to keep on a home-prepared diet. I think a home-prepared diet is the gold standard for diagnosis, but certainly not for maintenance. So, having made the diagnosis, we would want to maintain on a limited antigen diet or a hydrolyzed diet. Some animals, as I'd mentioned previously, cannot handle any commercial diets but may be asymptomatic on any home-prepared diet. And that was the case with that bad-tempered cat Diabolo that I showed you earlier. Certainly, you should consider taurine if you have to maintain an animal on a home-prepared diet. But there are a few that are asymptomatic on a home-prepared diet but symptomatic on any commercial diet. And corticosteroids if necessary. So we've eliminated food allergy, and I think I should emphasize that if you do serology for environmentals and you get positives to environmentals, you still have to pursue food allergy before you would embark upon immunotherapy for atopic dermatitis, because a significant proportion of cases can have the two diseases side by side. Atopic dermatitis is much less well defined than the canine condition. It is associated with IgE, although the possibility of what we call in the dog atopic-like dermatitis with no IgE probably does exist in the cat. In contrast to the dog, there's no good evidence of inheritance apart from one report of 3 littermates. Histopathological and immunological studies are rather similar to those of the dog. There's an increased number of Langerhans cells, increased number of IL-4, CD-positive T cells. Those are the types of cells that we classically associate with atopic dermatitis. No studies yet done on barrier function in the cat, which is emerging as a very important issue in canine atopic dermatitis. The diagnosis is largely by clinical signs, by excluding other possible causes. And evidence of IgE should be sought by intradermal tests or serology, largely to select allergens for immunotherapy or for avoidance where practical. So the clinical signs of atopic dermatitis in the cat can be associated with any of the documented feline skin reaction patterns that we've described. And don't forget recurrent otitis externa, complicated by malassezia or bacteria. In the dog, this is a very important manifestation of atopic dermatitis, and indeed many dogs can have otitis as their sole manifestation of atopic dermatitis. Why not the cat? And I think people, particularly in the United States, are becoming more aware that indeed recurrent otitis externa can be a manifestation of atopic dermatitis in the cat. Are we going to do skin testing? Well, you can if you like, but it's not easy in the cat. You need anesthesia. It's difficult due to the thin skin, and they're not easy to read. This actually on the right was a very, very strong positive skin test, but although you can see a few little bumps, it doesn't really show up nicely like it does in the dog. And remember that normal cats will have some reactions. All normal dogs, cats, and people have some IgE, and you'll get some positive skin tests. And skin testing was not closely associated with serology, and the question is, what is the gold standard? Which is best? Is it skin testing or is it serology? And I'm afraid nobody can answer that. So if we're going to do serology, the question is, can allergen-specific IgE be accurately measured? It's certainly offered by many laboratories, and firstly, let's look at the cloned alpha chain of the Fc epsilon receptor, which was marketed by Hesker in the United Kingdom, but it's not available in the United Kingdom, though it is in Europe and, of course, in the United States. And there are 3 publications here which cast considerable doubt upon the sensitivity of this reagent, particularly the second one, Lee Fowler et al. The reagent had a sensitivity of only 22.7% when compared to intradermal skin test in 11 specifically sensitized asthmatic cats. So they knew what these animals were sensitized to. It had been done experimentally, but this serology was only able to pick up 22.7%. So that reagent is not seen to be very reliable and sensitive for cats. What other assays are available? Well, this is all quite controversial. Polyclonal antisera, people always pow polyclonal antisera. They say they cannot be rendered specific, but that's absolutely untrue. They can be if they're made properly. And there are some of these that have been used experimentally, but I'm not aware of any that are available commercially. Monoclonals are offered, but I don't know of any published data on the specificity. And I think when you're choosing a laboratory to send your serology to, you need to be a little bit careful about requesting some good data on the specificity and sensitivity of the test that's used. Cross-reacting monoclonals are interesting, and Bruce Hammerberg at North Carolina State University raised an antibody against the heat-stable epitope of a monoclonal canine IgE that cross-reacts with IgE of most species. This is employed at Avacta Animal Health, and as far as I'm aware, this is the only reagent that's been shown in published studies to show significantly high levels of IgE to a relevant allergen in presumed atopic versus normal cats. And this was a study which was presented at the World Congress of Veterinary Dermatology in Hong Kong, and I refer you to the left at the top. And if I can just get this thing to appear, there we are, there's the arrow, to this, which is the levels of native Dermatophagoides farinae specific IgE. This is the most important allergen in cats, as indeed it is in dogs. And you'll see suspected atopic cats have a median level of around 10 units, whereas the non-allergic control cats, which actually had gastrointestinal disease, have a median level of something slightly over 0. So highly significant difference for Dermatophagoides farinae, the most important allergen, between the allergic cats and the normal cats. So we've made a diagnosis, we've done serology, we know where we're going to go, what options are available. Firstly, corticosteroids, topicals. Cortivance, or hydrocortisone acetonate, is very effective in cats, as has been reported in the literature, but it's not licensed for cats. This reagent is metabolized in the epidermis, and so it doesn't, it's not absorbed, and it doesn't have suppression on the pituitary adrenal axis. Then methylprednisolone at 1.41 mg per kg at induction and 0.54 mg per kg every other day for maintenance. Methylprednisolone by injection, and then I want to draw your attention to triamcinolone. There was an excellent study done on, I think, about 50 allergic cats in Southern California comparing methylprednisolone with triamcinolone. And triamcinolone turned out to be an excellent corticosteroid and was perfectly effective every other day for maintenance, and was about 1/8 of the potency of methylprednisolone. So it's a cost-effective treatment. And those of you who've never tried it, I would urge that you give it a go, because it's very effective and relatively inexpensive. Antihistamines will sometimes be helpful. Chlorpheniramine is supposedly, I think on most reports, the most effective antihistamine in cats. Essential fatty acids may give some help. Cyclosporin, the dose is 7 mg per kg. Check for FELV and FIV. And there's controversy, of course, about toxoplasmosis. There have been a couple of reports of fatal toxoplasmosis following cyclosporin reported in the literature, so you might want to check serology. Now, if it's completely negative, then you better be pretty careful that cat's not going to go outside and catch some mice, or it might contract toxoplasmosis and it will not be able to respond to it. Some people say that if you've got IgG antibodies, that's fine, but if you've got IgM antibodies, if your laboratory can detect those for you, then this indicates a recent infection and it might be unwise to use it. And immunotherapy, which I want to spend a little bit more time on. This was a retrospective study I did while still in the United States, looking at the responses of individual syndromes in 42 cats undergoing immunotherapy. And hair loss, we had about a 53% improvement. Miliary dermatitis, 67% improvement. Eosinophilic plaque, 72% improvement. Eosinophilic ulcer, 94% improvement. Linear granuloma, which is sometimes but rather rarely associated with atopic dermatitis, they all got better. And notice otitis externa, 4 cases with pretty good improvement. Lower respiratory tract disease or asthma, which we'll come to later, had good improvement. So immunotherapy is actually very effective in cats, and I would urge those of you that haven't tried it to be using it. And it's the only way, I think, in which we can possibly get a complete resolution of the clinical signs. Now, if we think of the atopic diseases, in man, they comprise allergic asthma, hay fever, and atopic dermatitis. And many patients will have a combination or progress from one to the other. What about cats? Well, cats suffer from atopic dermatitis and also from asthma. And some cats have asthma and concomitant skin disease. So the question is, can we justify feline asthma as being atopic in nature and allergic in nature? Poll number 3, what's your approach to chronic coughing cats? Do a complete workup, including radiographs, bronchoalveolar lavage before deciding on therapy. Use injectable methylprednisolone acetate for control without extensive investigation. Use bronchodilators both to aid diagnosis and then for therapy. Go straight to serology for allergen-specific IgE and then prescribe immunotherapy. And E, a combination of A and D. Okay, well, I think that's excellent. We've voted to do a complete workup, including radiographs and bronchoalveolar lavage, before deciding on therapy. And the next top vote was for a combination of A and D. So yes, do a complete workup, and then go to serology for allergen-specific IgE. So that shouldn't be go straight to serology. So a combination of A and D, for me, makes quite a lot of sense. So is feline asthma an allergy? And the best paper by far that's been written on this topic is by Carol Raniero in the Veterinary Journal, 2011, page 28, volume 190, which is an excellent description where she goes into all the evidence that favors the conclusion that asthma is indeed an allergy. Characterized by bouts of coughing, wheezing, or dyspnea, increased bronchial, interstitial, or mixed radiographic changes, flattening of the diaphragm, and increased distance between the heart and the diaphragm, abnormal bronchoalveolar lavage cytology, and eosinophils should be prominent. The earlier reports didn't emphasize this, but I think people now are recognizing that eosinophils should be prominent. You've got to eliminate parasitic conditions, Ileus strongus abstrusus particularly, and diarrhea if you're in that part of the world where it occurs, and then response to bronchodilators. Here's a nice before and after picture, before therapy, showing increased distance between the, let me just get the cursor to operate for me, increased distance between the heart and the diaphragm, and certainly infiltrative lesions in the lung. And here is after allergen avoidance. The heart is now resting on the diaphragm, and there's a much clearer view. Now, Carol Raniero, who wrote that paper I referred you to, has done some fascinating work on an experimental model of feline asthma. She induced asthma in cats by sensitizing them to house dust mite or Bermuda grass antigen. She then evaluated subcutaneous versus intranasal allergen-specific rush immunotherapy in experimental asthma. And subcutaneous was the most effective, resulting in total remission. So she made these cats allergic, and then she cured them with subcutaneous immunotherapy. And then she did show two other interesting things. One, that your selection of antigens when you're doing immunotherapy didn't have to be 100%. You got some protection by doing immunotherapy with perhaps related but not the proper allergens that were inducing the disease, although the best results were achieved using the complete allergen repertoire. And then finally, the worrying thing that we've always worried about in dermatology, oral glucocorticoids diminish the efficacy of allergen-specific immunotherapy in experimental feline asthma. Very recent publication this February in the Veterinary Journal. And she gave 10 milligrams prednisolone or an inhaled steroid by inhalation for 6 months or a placebo, and then immunotherapy for a further 3 months. And the oral prednisolone had a significant inhibition on the response to immunotherapy, but the inhaled steroid did not differ from placebo. The question is, does this hold true for atopic dermatitis, where we often will use corticosteroids initially? So what are the therapeutic options? Well, in the literature, prednisolone 10 milligrams daily and then perhaps going to every other day is preferred. But what about triamcinolone? Nobody has used triamcinolone or methylprednisolone in published reports, and I would suspect they might be just as effective. And these other steroids by inhalation, and then bronchodilators, short-acting beta-2 agonists, long-acting beta-2 agonists. But allergen-specific immunotherapy and or allergen avoidance offer the only permanent cures. And this was an excellent paper published in a French human allergy journal. Feline asthma, the treatment of feline asthma with allergen avoidance and specific immunotherapy, experience with 20 cats by Christine Prost. 18 of 20 cats with asthma were skin tested, positive results in 15, most had house dust mites. Avoidance of dry cat food cured 3 that were allergic to storage mites and had been obviously inhaling storage mite antigen whilst they were eating their dried cat's food. 12 were subjected to immunotherapy. 8 resulted in total remission. 4 still needed inhaled bronchodilator plus or minus corticosteroids. But I think although this was not a controlled study, those of you with experience in feline asthma, I think would recognize that this sort of response is pretty encouraging. So in conclusion, I think that, particularly if we look at the excellent work done on feline asthma by Carol Raniero, there's need for more immunologic research in cats, looking at the other conditions, the GI conditions, the food allergy, with skin signs and the atopic dermatitis. We do need more immunologic research. Dermatitis, inflammatory bowel disease, and asthma are all candidates for an allergic etiology. And I think it's time that we as clinicians put more effort into investigations and targeted therapy in potential cases of allergic disease rather than an automatic life sentence to a life as corticosteroids. So I think although depomedrone is very, very convenient, I think that the less depomedrone we give and the more effort we put into trying to identify a specific etiology for these allergic diseases, then the better our cats will be. So cats deserve better. Thank you very much.
Okay, well, on behalf of Webinar Club, I would like to thank Professor Halliwell for a fantastic webinar. We do have some questions for you, Professor, so we will try and get through as many as we can. The first question that I have for you, what do you use to moisten the skin for skin scraping?
Oh, I think you just put a little bit of liquid paraffin on the skin is fine. I think that's the best thing to do because you want to keep it quite viscous. You don't want to put just water on there. I think a little bit of liquid paraffin or mineral oil.
Great, okay. The next question I have, to prove the barbered effect, do you pluck the hair from the cat or do you find one on the floor that's been licked out?
I actually pluck the hair from the cats. I think this is more convincing. It's sometimes difficult to find it on the floor that's been plucked out. I mean, go to where you've got sort of what look like stubbly short hairs and pluck some of those out and look at them under the microscope, and then do show them to the owner, because that's very useful to convince them of the true nature of this hair loss.
Okay, next question. Could you give an example for a good home prepared diet?
Well, cats are rather fastidious eaters, and I think no two cats are the same. You could use fish and potato, that's freshly prepared fish and potato, freshly prepared chicken and potato, or freshly prepared chicken and rice are diets I think that people prefer. Fresh tuna, if you have it in your local fishmonger, they usually will eat this pretty well with potato or rice.
Okay, and which food proteins are commonly associated with allergy in the UK?
No good data on this. In cats, I presume the question is. There's no good published data on this. Recently, in veterinary dermatology, was a sort of composite of all the foods. And I think beef generally worldwide was the most significant. Fish actually didn't rate that highly in cats, but I don't think there's really good data that's been collected in a systematic way in the UK.
Okay, the next question I have, how long can you safely feed a home-prepared diet for the food trial?
I assume that means without supplementing with taurine. Um, I'm assured by researchers at pet food companies that if you've got a fresh source of protein, be it chicken, be it beef, be it lamb, be it fish, and you don't boil it, but you perhaps microwave it, that you're fine for 8 weeks without necessarily supplementing with taurine. But after that, on a long-term basis, you're certainly going to need supplementation with taurine, and the pet food manufacturers can advise you about the best source of that.
Okay, another question about the diet trials. Will a diet trial be ruined by a cat who is catching mice?
Good question. Nobody has looked at the possible relevance of mouse allergy in cats as a cause of food allergy. I mean, from a strict point of view, yes, of course it would. How relevant that is, I don't know, but actually the proof of the pudding is in the eating, in that if you are aware that your cat has caught, or that your client's cat has caught a mouse, then observe it carefully and see if it gets worse or not.
Okay, the next question, have you seen pseudomonal otitis as secondary to allergic disease in cats?
Yes, but fortunately not very commonly. I think it's fortunately not as common as it is in the dog, but yes, it is reported as occurring.
Okay, next question, is there any age predilection for food allergies?
Excellent question. In the dog, there certainly is, and with the majority starting before a year of age, or 42% before a year of age. In the cat, we don't have good data on this. Nobody has done sufficiently large case series to be able to get accurate data on it. I'd suspect that it's going to occur in the younger cat as it does in the dog, but we don't have good data.
Okay, just time for a couple more questions. Do you think that Feline has a place in psychogenic alopecia?
Interesting one. I don't know. Arguably it might. I'm not aware. What somebody needs to do is a comparative study, a crossover study between Feline and clomipramine, which should be a very interesting study, which hasn't been done. I mean, the classic sort of diagnostic criteria is response to clomipramine, as I mentioned, but Feline may certainly help, and I'd love for somebody to do a crossover study on that.
Okay, somebody else has asked, after how long should you repeat methylprednisolone injection in cats?
I guess, being the devil's advocate, I should say not at all, never. But in practice, according to the required effect. But you see, that's a problem I have, and certainly when I was in general practice many years ago, I certainly used to use it a lot because it was so convenient. But you've got a problem when it's wearing off. You know, you have a big sort of surge of activity, of anti-inflammatory activity, then it gradually wears off. And when do you start up again? Which is why it's so much better and easier to control it with oral corticosteroids, where you can get on a more even plane of anti-inflammatory activity. And I hope, if only one take-home message from here, I hope that some of you will perhaps try oral triamcinolone as a way of managing these, because I think you'll find it really is very rewarding.
Okay, there's actually another question on triamcinolone. How often do you use it?
It's initially, this is of course oral, it's initially daily, and then when it's controlled you can go to every other day at about the dosage that I gave you.
Okay, somebody's asked, what about betamethasone in cats?
I'm not sure that I see a need for quite such a potent steroid. I think most clinicians that are or dermatologists that are specializing in feline dermatology would avoid the use of that drug, and as I say, come back with methylprednisolone orally or triamcinolone orally.
Okay, just one last question. Is there a UK licensed version of triamcinolone?
I am not aware of it. I didn't go on the website and check. I know many people use it, and they use it very much in the United States. I'm not aware of that, but I could right now go onto the VMD website and check. So I can't be certain on that. But certainly under the cascade, it would be perfectly acceptable to use it.
Okay, well, I think that's all the questions we've got time for. So thank you very much once again to you, Professor Halliwell.
My pleasure.
Also, thank you to our sponsors for this evening, Avacta Animal Health. The recording and the certificate of attendance for this webinar will be available later this week, and we will email you all as soon as they're ready.